I've heard it said that when a woman becomes pregnant, like the different changes that happen in the body are just like, where do you even begin? Right. But I'm guessing there's a lot to be said about it. So I'll let you start wherever you think is good.
Okay. So about 68% of pregnant women report a sleep disturbance during pregnancy.
Okay.
And it increases from 13% during the first trimester to 66% in the third trimester.
Okay.
97.3%, so nearly all women.
I was going to say, yeah.
Report that when they're pregnant, they wake up more frequently during the night.
Okay.
And it increases as the pregnancy progresses.
Aha.
We think this is due to a couple factors. One is this increased urinary frequency, right?
Yes.
It's pretty common knowledge to most people that pregnant women pee more often. That doesn't just stop at night. Pregnant women also have an increased risk of headaches.
Okay.
And then because of these changes going on in their body, especially with the fetus stealing chemicals and nutrients from the woman, they have an increased risk of leg cramps during this time.
Okay. They're battling it out for nutrients.
Yeah, well, and that's one of the reasons why women have more osteoporosis than men is because the baby steals calcium from the woman.
Sure.
And the more children a woman has, the greater her risks of osteoporosis.
Right. Exactly. She had to give away all her calcium.
Right.
Yeah. Okay. So it sounds like just to start off, there's almost all women. What was the statistic you had about almost all women? It was like 97.8.
3%.
Yeah. What was that again?
Have an increase in the number of awakenings at night.
Okay. When pregnant?
Yep.
Okay. Wow. So it's kind of like it's kind of a foregone conclusion for women who are pregnant, right?
Right. And I'd love to know who those 2.7% are who don't.
I was going to say we should get them on this podcast.
Yeah. But that whole losing nutrients thing is why prenatal vitamins are so important to women.
Yes. Good point. Yep. I always wondered about that actually. I'm like, why are prenatal vitamins so important?
Well, and they're designed to replace a lot of nutrients. So they have more calcium, they have more magnesium, which helps with the leg cramps. And so these vitamins are different than what you would take at other parts of your life because they're targeted to specific nutrients that can be lost while pregnant.
Right. They say that even if you're thinking of becoming pregnant, you should start taking them.
Correct.
So that you're ready to go. Okay. So you also had mentioned some different statistics regarding like the different trimesters for women.
Right.
So do you want to say anything more about kind of throughout the pregnancy? What are some things that women encounter?
Yes. So, just a brief overview again, pregnancy is broken into 3 trimesters.
3 trimesters.
And sleep changes at each stage.
Yeah. Yep.
So during the first trimester, most women report an increase in drowsiness and sleepiness. And again, this is almost stereotypical, right? Pretty much everyone knows that newly pregnant women sleep more.
Yeah.
And this leads to an increased desire to nap during the day. Right? So, if you look at this from a systemic perspective, right?
Yep.
It's normal, it's biological, but do we account for it in the workplace?
I was going to say, no.
Right.
I know after a woman gives birth, there's, she can be accommodated for nursing breaks and such. But what about first trimester nap breaks?
Right. and I mean, this is the cynical side of me.
Sure.
Pregnancy is not a disability, it's a state. So it's not protected by the Americans with Disability Act.
Oh my goodness, that's right. Yeah. I think we should right to our legislators.
Yeah.
For real.
I mean, sleep is really creeping into society because the fact that teenagers have this later sleep phase
Yep.
is why there's so much push for delayed start time for high school students.
Yeah, that's right.
We tend to do this backwards. So
Okay.
anyone who's had small children know they're up early in the morning, right?
Oh yeah. Yep.
But they start school last, right? A lot of elementary start close to 9 o'clock.
Yep.
And then when you get up to high school, where students, you kind of prying them out of bed at noon to 1 o'clock, they start the first time. And so they're the earliest to school. Plus, if they have to ride the bus, it's even earlier. And so what they have found is this affects academic performance. It affects mood. It affects behavioral issues. And so you're seeing this continued push toward delayed start times for high school students because biologically it makes sense. And, the schools tend to resist it. But we know that school performance improves. So you'd think they'd be on board with it. So then it's, why is this such an issue? Why isn't it just a, yes, that's correct, let's do that? And that's where childcare comes in, right? If your child goes to school earlier in elementary, then you have more time you have to cover for childcare after they get out.
So true. Yes, exactly. Problems that have slutions.
Yeah. Well, it's just like daylight savings time. We know that is a horrible thing. It actually doesn't save energy, which was the original purpose of it.
Sure.
When we spring ahead, the day after we spring ahead has the highest rate of auto accidents and heart attacks.
What?
Except for in 2 states. Arizona and Hawaii, who don't have daylight savings time.
Oh my gosh. I think we could almost do a whole episode on daylight savings time. And if anyone knows about the impact of daylight savings time, it would be you, I think, on the American sleep issue, right?
Yeah. Well, it also depends on the person. So early birds love it when we spring ahead and hate it when we fall behind.
Yep.
And people who are more of a night owl have the opposite reaction. And so it also affects their performance, their mood, their level of sleepiness, just based on where they're at biologically.
Well, I'm sort of a night owl, and I every year I look forward to the fall back. Right where we turn the clock back because that's like the advantage time, right? It seems
and
like
I'm the opposite. So when we fall back, I have to struggle to stay awake till my bedtime. But when we spring ahead, it's like, yay, I get to go to bed earlier, and I'm getting up when I wake up anyway.
Oh, okay. Yeah. See, everybody's different. So, so back to the pregnancy. I mean, is there so we were talking about the nutrients. We were talking about when the baby is kind of stealing nutrients from the mother, there's an increased risk of like leg cramps. And so kind of what's happening as the pregnancy goes onward?
Okay. So during that first trimester, estrogen and progesterone increases as the fetus matures. And again, those are in general sleep promoting hormones.
Sure.
And they actually peak approximately 50 to 60 fold just before delivery.
Okay.
The increase in estrogen and progesterone increases GABA production.
Okay.
So GABA is a neurochemical. And actually you have GABA receptors throughout your body. And GABA is a relaxing or a sleep promoting hormone or a neurochemical. Okay. So when estrogen and progesterones rise, the GABA increases. And so when you think of things like gabapentin, that's because it's targeting the GABA receptors.
Ah, gotcha.
Okay. So as those hormones and GABA rise, women report an increase not only in the amount of sleep they're getting, but also in feeling more somnolent or sleepy and fatigued during the daytime. So at the
Okay.
initial part of pregnancy, women fall asleep much faster and they tend to start going to bed earlier than they were pre-pregnancy.
Okay. Sure. That makes sense.
But as the first trimester progresses, the quality of sleep and the number of awakenings start to increase. And we think a lot of this, again, is that frequency of urination. But also, you'll hear pregnant women talk about their body hurting.
Yeah. What's
And
with
so
that?
it's also this musculoskeletal discomfort that happens.
Yeah. Do you know why that is?
No, I mean, not officially, but
Sure.
but when you think about it, the changes a woman's body goes through during pregnancy is significant.
Sure. It could be any number of things.
Yes.
Well, and I've even heard, like, again, when carrying a baby, like your body, even when you're up and walking around, it changes how your body moves, the muscles, especially as pregnancy progresses and the baby becomes heavier, right? So
Right.
I've heard women having, and maybe you're getting to this later, but like even in the third trimester, it's like, I can't get comfortable.
Right.
Right.
Well, and one of the things that happens during pregnancy is bone structure changes too. The pelvis starts to open up
That's
so
right.
that the baby has a more clear passage. And so you would think that if bones are moving apart,
yeah,
that would,
ouch.
I mean, it's kind of like growing pains, right? It would
for
hurt.
real. Yeah, no, that would definitely hurt. Mm-hmm.
Yeah.
Yep.
And then you also have prolactin levels rise. So the body starts preparing itself for milk production. So breast size increases.
Sure.
And so if you think about that, then, there's that stretching and the changes in the musculature. And so, there's just so many changes going on.
Right.
Pregnancy is uncomfortable.
Is prolactin a hormone? What's prolactin?
Yeah, prolactin is a hormone. It increases milk production.
Right. Okay.
So some psychiatric medications also increase prolactin, especially a lot of the second generation antipsychotics.
No way.
So there are even men who are on these medications to help with their mental health that will start to lactate.
What? I did not know that.
Your psychiatric provider does.
Yeah, totally.
But yeah, so anything you put in your body changes your chemical structure and can bring about changes. And psych meds are no different than that.
Yeah, it's just amazing. Now that we're talking too about sleep and pregnancy, and now that you mentioned medications, it's like we're talking about one very specific situation, like a woman who is, going through pregnancy. She's not taking necessarily any medications, right? But then you add in, what if a woman, because I know there are certain medications that women can take safely in pregnancy, both like psychotropic and otherwise.
Yes. So medications have a class to them.
Sure.
And the class for women is whether or not it is
controlled
heterogenetic toxicity to the fetus. So there are certain medications that women might be on for their mental health that they have to go off of or change to a different type because if you think about it, the baby is getting the nutrients for the mother. And so you're talking about things that cross the placental barrier and also affect the baby. So like when we talk about cocaine babies, cocaine easily crosses the placenta and that affects the child. And then when the child is born, that child can be going through withdrawal. But the same is true with a lot of other chemicals we put in our body, is that it crosses that placental barrier and can affect the baby.
Very true. Okay, so so you said that's how they determine some of the medications that if it's safe to take during pregnancy is, what is it called? The placenta, or what did you call it? Something
Placental
about,
barrier.
yeah. Or there was something you said about safety. It was a big word.
Oh, it's tetrogenicity, I think is the correct term.
Heterogeneity. Okay.
Yeah. But basically, it can not only affect women during pregnancy, but there are also things that can cross through in breast milk. And so, like, if you're on these medications and you're thinking of becoming pregnant, or you just find out you're pregnant, you really need to talk to your psychiatric provider and go through, are these medications safe? And that's why, I think women get tired of it. Is there a chance you may be pregnant?
Yeah.
Well, the reason they're asking that is because there are a lot of medications that pregnant women can't take, not only for her safety, but the safety of the baby.
Right. Yes. Great point. So maybe this is a good time to transition to, is it too soon to say what happens after the baby is born? I know I feel like there's so much we could probably cover with pregnancy.
Well, let's finish pregnancy first.
Great. Let's do it.
So during the second trimester, estrogen and progesterone levels continue to rise, which leads to an increase in sleep quality, but it's still less than their pre-pregnancy state.
Okay.
And sleep quantity also increases, and at this point, it's often greater than their pre-pregnancy state. But sleep can be disrupted during the second trimester by fetal movements.
Sure. Yep.
Uterine contractions.
Okay.
During the second trimester, women are more prone to rhinitis or nasal congestion.
Really?
There's an increase in musculoskeletal discomfort, especially because as the baby gets larger, it's pushing on things.
Yeah.
Abdominal mass increases, so it starts to get more difficult to get comfortable.
Yep.
And about 28% of women in the second trimester reported that their total amount of sleep on average was less than 7 hours a night.
Really?
And it's significantly less for Black and Asian women.
No way. That is interesting.
So, I mean, now you've got not only what stage of pregnancy you're in, but now you've got these race and ethnicity factors coming into play too.
Yeah, very true. Very true. I had no idea.
Then the woman transitions into the third trimester, and sleep is usually the worst during the third trimester. The amount of sleep they average on night decreases by about 30 minutes, and that's on top of the decrease that happened earlier.
Wow.
And then short sleep, which is defined as less than 6 hours, is also linked with the gestational age of the mother. So now you have another factor coming into play. So approximately 1 in 6 pregnant women are over age 35 at the end of their pregnancy. In the past, it was called the geriatric pregnancy, which is really kind of insulting.
Wait, so it's no longer called that?
No, the current term is advanced maternal age, which is a little bit gentler, but I think they could still come up with something better.
Yeah, I think so too. I don't know what it would be, but go ahead.
but it does change things. So pregnancy in women giving birth over the age of 35 are linked with even shorter sleep duration, a greater risk of insomnia, and worse sleep quality.
Sure.
Advanced maternal age with this short sleep duration is linked to a lot of pregnancy complications, such as risk of miscarriage, preterm birth, placenta abrupta, which is where the placenta detaches from the wall of the uterus and starts this hemorrhaging. They're more prone to stillbirths, cesarean sections, chromosomal aberrations. So if you think about it, as a woman gets older, she's born with all the eggs she's going to have. And so as you get older, there's a decrease in available eggs. And some of those may not be as viable as they were younger.
Before. Right.
Yep. They're also more prone to multiple pregnancies, so they may see more twins.
Yeah.
They're especially prone to preeclampsia, which is this dangerous rise in blood pressure that happens during pregnancy.
Right.
And actually, there's just an NPR story about the dangers of preeclampsia. And the United States actually has a relatively high birth complication rate. And part of it is because we're not recognizing preeclampsia as much as we should.
Okay.
Older women who are pregnant have an increased risk in gestational diabetes. And then there's this thing called telomeres. So every cell has telomeres, which is this change of molecules that are attached to it. Every time a cell divides, it loses a telomere.
Okay.
So as we get older, the cell's ability to replicate itself decreases, and it gets to the point where the cell can no longer replicate. So if you think about things like hair, skin, nails, a lot of this is due to those cells losing their ability to replicate. But this is across every cell in your body.
Sure.
But it also has shorter telomere length in the baby. And so this increases the risk of pediatric diseases, shorter lifespan for the child, and even puts them at risk later on in life for certain cancers.
Okay.
So women listening to this might be panicking right now. This is an increased risk. It doesn't mean it's going to happen.
Okay. Good point.
And so it's a wonderful thing to talk to your doctor about. Family history matters. The health of the mother matters. But this is not to say that women over age 35 shouldn't get pregnant. That's absolutely not true.
Okay.
And so I want to make sure people who are thinking about having a child are like, oh my God, I'm too old to do this. You may not be. Go talk to your doctor. There are risks, but there are lots of things they can do. So like preeclampsia, for example, that huge spike in blood pressure, that can be monitored and addressed throughout the pregnancy.
Right. Exactly. Right. I'm so glad you said that. Yeah.
Yeah. Well, you hear this a lot because they come out with, like if you're on like Ambien, Lunesta, or Sonata, you have an increased risk of developing Alzheimer's later in life, right? That freaked a ton of people out.
Oh, I'm sure.
But it's a 4% increase. So if you have this huge family history of Alzheimer's, that might be a concern. If you have no family history, like if you're, chances of developing Alzheimer's are 0.001. Well, now it's 0.004. Right. So it doesn't mean it's a definite likelihood. It means it's an increased possibility. And just to address that, there's new research coming out that these medications do not have an increased risk of Alzheimer's. It's not causation, it's correlation.
Okay.
So people who have poor sleep tend to have a greater risk of Alzheimer's, but they also tend to have that treated with medications. So there's this new thing coming out saying that when this came out, we assumed that the drugs were causing Alzheimer's. And now it's like, no, people who are in the early stages of Alzheimer's sleep less, and they're more likely to be put on medications. So this is where the media comes into play, because we get these horror stories in media, but there's really a lot more nuance to it. And of course, media is always going for sensational, so it freaks people out.
Yes. No, I really appreciate both things that you just addressed. So one would be, the first piece was like, I'm not saying that women over 35 shouldn't, try to have children or, it's like, think about all the different factors, get all the cards on the table, right? And then you're talking about likelihood. You're not talking about it's actually going to happen, right?
Right.
And then the other piece about sometimes the studies that we hear about, there's more to the story, right?
Right.
Like with what the media can portray as like, oh, this medication is causing this. And it's like, well, let's look at the actual research here. Like, what does it say?
Well, and I mean, back before marijuana was legal in Minnesota, you could get a medical marijuana card for sleep apnea.
Really?
Right.
I didn't know that.
And so when that came out, you had a lot of people coming to your office saying, well, I've got sleep apnea. I want to look at this medical marijuana thing.
Okay.
What most people don't realize is that was based on a study of 11 people. So it's really, really small.
Yeah.
And what we know is that marijuana decreases the amount of time you spend in REM sleep.
Decreases the amount of time?
Correct.
Okay.
REM sleep is where sleep apnea is worse. So if you decrease REM sleep, you're going to have lower sleep apnea.
Okay.
But what they reported is that it decreased sleep apnea. What they didn't tell you is that all of those people still had sleep apnea. It was just slightly less severe than it was before the marijuana.
Okay. I'm really actually, I want to stay on the marijuana for just 1 second, because another thing, again, that I've anecdotally heard back to women who are dealing with menopause and who are having sleep difficulty, a couple different people I know have said like, oh, these THC gummies, I'm trying those because I've tried everything else and I just can't, I'm having such an issue with menopause and sleep. And so do you have any thoughts on like, I guess this is a huge topic again, but you had said something really interesting about cannabis affecting REM sleep. So any thoughts you have just about when women are kind of saying like, oh, use THC to help with your menopause sleep issues?
Absolutely.
Okay.
And my answer is we just really don't know.
We don't know.
So marijuana has been illegal for so long that it wasn't studied. And now that it's becoming increasingly legal, like one of the things Minnesota did is they included in the marijuana law money to study the effects of marijuana on various conditions. But marijuana also isn't complete, right? There's different tinctures, there's different flowers or parts of flowers that they're using. They add in other additives or chemicals. And so when you say marijuana, it could be 1,000 different variations.
So true.
So we're starting to get some ideas on marijuana, and that would be a whole different subject. But I do know we're on time, so I want to get back to sleep and pregnancy.
Yes, of course.
So in the third trimester, poor sleep is linked with an increased risk of postpartum depression.
Okay.
So on the PHQ-9, which is something most people in behavioral health are familiar with, it's a depression inventory. The third item in there, which is, are you sleeping too much or sleeping too little, may actually be a really good single item tool for identifying those who are at risk for postpartum depression.
Okay.
Kind of consider it like the canary in the coal mine.
Okay.
Because people who score high on that, it's associated with a significant risk of postpartum depression within the first 6 months after birth.
Okay.
So there was a study in 2017 that found that non-depressed pregnant women who reported difficulty falling asleep in the third trimester, so they have no history of depression, were 4 times more likely to experience depression at 6 months postpartum.
Wow.
Right. And this is where CBTI can come into play. And we actually talked to Nystrom's mother-baby program about this because 64% of pregnant women who received cognitive behavioral therapy for insomnia experience symptom remission. And what we're finding out is that may actually significantly decrease or prevent peri and postpartum depression.
Okay. Gotcha. Wow.
So in general, in the third trimester, women report increased sleep fragmentation, restless sleep, difficulty falling and staying asleep, increased daytime sleepiness, and fatigue. they have an increased risk of GERD or gastroesophageal reflux or severe heartburn. And that affects about 75% of women.
Wow.
Pregnant women.
Pregnant women. Okay.
Yes.
Yeah.
They have an increased risk of restless legs. Their levels of sleep apnea go up. And in fact, sleep apnea in pregnant women is 2 to 3 times more likely than non-pregnant women. So the percentage of sleep disordered breathing or sleep apnea ranges from 10.5% having it during the first trimester to 27% in the third trimester, so 1 in 4. Wow. And we know that's sleep apnea or sleep disordered breathing increases the risk of gestational hypertension, preeclampsia, and gestational diabetes.
Wow. Okay.
The interesting thing is that we have guidelines for how to treat sleep apnea and whether it should be treated in all populations, but there are no recommendations for pregnant women. And part of that is this belief that when the birth happens, that should resolve itself. So things that disrupt sleep in the third trimester, again, you have the frequent urination, you have the fetal heartburns or fetal movements, you have heartburn, you have orthopnea, which is shortness of breath when lying flat. So gravity pulls the baby down, which allows the diaphragm to move freely when you're laying flat. It makes it harder to take a breath in. They again have an increased risk of nasal cramps, sinus congestion. You mentioned earlier difficulty finding a comfortable sleep position. And then restless leg syndrome increases when estrogen levels peak. And the interesting thing is a lot of the medications we use to treat restless leg syndrome, which is really effective and most people don't have to suffer from it, aren't used for that same thing we talked about, that it can affect the baby. Right. Wow. So the last part of this is what happens to sleep after the baby is born?
I'm sure a lot. For a lot of reasons.
So postpartum women tend to take longer to fall asleep. They tend to sleep less of the time they're trying to sleep. But their deep sleep or that restless sleep returns to normal levels. But here's where, again, society comes into play. Because in the United States, most women are the ones who provide the care and feeding of the newborn. And this is significant because, again, poor sleep quality, disrupted sleep, and insomnia increase a woman's risk of developing postpartum depression. So we need to have another discussion within our society about how do we lessen this burden on women so that it affects their health less, but also just because it's fair. I mean, having a newborn baby who's crying all the demands, being sleep deprived, having your body recover from all these significant changes, it's a lot.
It is a lot. Yeah, totally. And then on top of it, like you said, the risk of postpartum depression, I think you said, increases when there are increased sleep difficulties, right? In the final trimester? Yeah. And, you know, we talk a lot about postpartum depression, but there's also anxiety. And at the extreme cases, there's postpartum psychosis. So, I mean, there was a case, I don't know how long ago, but it was when a mother drowned her children in the bathtub. And she was psychotic at the time, and she had just given birth to a child. And so even with postpartum depression, it's not something just to say, you're going to get the blues after pregnancy. It can be a serious risk to the mother and also to the newborn. Exactly. It's super important to address. And so, and addressing sleep is just one of the ways, it seems like, to prevent or minimize postpartum depression.
Right. And
Yes.
and I mean the other thing is like Nystrom's has a mother baby program. And so
Yes.
do a lot of other institutions. And those should be utilized more frequently. Especially for people who have mental health concerns before pregnancy, but even people who, in the past have had a child and they had postpartum depression.
Yeah.
Because the psychiatric practitioners there know which medications can be used in pregnant women. You have therapists who are skilled in helping women realize the things that they can do to help themselves. And hopefully they're also helping their partners understand the things they can do to help the woman.
Exactly.
But I think, if people have concerns, there are these programs out there. Take advantage of them.
Well, exactly. And speaking of taking advantage of programs, I mean, would you be willing to kind of, as we're thinking about wrapping up our episode, give kind of a summary of what Nystrom offers with regards to sleep?
Sure. So the fact that Nystrom's added a behavioral sleep program is huge. And it's forward thinking. In fact, right now, we're the only one in the country doing this.
Wow.
Yeah. So when you look at a behavioral health population, 50 to 80% of people who have a behavioral health condition have a sleep disturbance.
Yes.
If you look at the manual of diagnoses called the Diagnostics and Statistical Manual, there are over 300 diagnoses in that. 147 of them have sleep disruption or sleep disturbance as one of the diagnostic criteria.
Wow.
So if you're a behavioral health organization and you're not addressing sleep, you are missing a huge, huge thing. We also know that treating sleep can prevent behavioral health conditions from forming. It can significantly help alleviate them. And for those conditions like depression that may be episodic, it can reduce the risk of having a future episode. So when Nystrom says they take a holistic approach to behavioral health, they really are doing that, and sleep is a vital component.
Yes.
The problem is a lot of patients, a lot of providers don't know we exist.
Exactly, which is why I'm so excited that you can talk about this.
Right. So we're training more and more people to do this therapy. But we're still lacking on demand by patients.
Okay.
But it can make a huge difference. And like for insomnia, we can significantly improve sleep within 6 to 12 weeks. And about 80% of those people will no longer meet criteria for insomnia disorder. We can even get them off medications and still have them meet criteria, because medications treat insomnia as a symptom. The behavioral sleep medicine treatments actually address the problem and cure it.
There you go. Good. I'm glad you mentioned that about medications too, because I know a lot of people will say, well, I can't do CBTI or I can't, do this program because I take a sleep medication, and they're just going to tell me to get off my sleep medication.
Right. And actually, there's some historical truth to that.
Okay.
That is changing.
Okay.
Like for me, I always tell patients I don't have a dog in the show.
Yeah.
So if you want to stay on your sleep medications, that's between you and your prescriber. But obviously, you're still having sleep problems. So I'll treat that. I'll make your sleep better and you can stay on your medication. If you want to get off your sleep medication, I can get you sleeping significantly better than you were on your medication, even as you're tapering off of it.
Exactly.
So the other thing with behavioral health is a lot of medications we use for sleep are also used to treat other conditions. So like trazodone is an old SRI. It's an antidepressant. It never worked well as an antidepressant because at the doses it was effective, people couldn't stay awake. So we prescribe it as a side effect for sleep. But a lot of psychiatrists will use trazodone to augment other antidepressant therapies. You know, when you look at gabapentin, we sometimes use gabapentin for sleep, but it's also used for fibromyalgia. It's used for restless legs. It's used for mood disorders. It's used for anxiety. So for me, it's like if you're on a medication and it's not treating something else and you want to come off of it, I'll help you. If you want to stay on it, I'll help you.
Yeah.
If you are ambivalent about it, but it's treating another condition, then let's talk to your prescriber and see if there are alternatives.
Yep.
But I don't want people to say they're going to take away my sleep aid.
Right.
The truth is, I can get you sleeping better than you are on the sleep aid. But if you're really attached to it and you don't want to go without it, go ahead.
Yeah.
I also have people who do CBTI and they don't benefit the way we would expect them to.
Okay.
And then we'll talk about adding a sleep medication. Some people need that.
Okay.
And so I tell people I'll beat your insomnia by hook or crook. The hook is CBTI. If CBTI doesn't work, then we add the crook, which is the medication.
Exactly. No, I think I'm, again, really glad that we could highlight that piece because I think just change can be intimidating in general. So if someone has something they're doing and they're like, this seems like the only thing that's helped me, I don't want to give it up. It's like, you're not saying give up sleep medication. You're saying we're going to address it one way or the other and see what we can come up with.
Yeah.
Yeah. It's just amazing.
And you know, I'll be honest with people. CBTI is a challenging therapy. Just like with other psychotherapies, there's a 40% dropout rate. It typically happens in the first 3 weeks, which are the most challenging.
Okay.
But if people stick with the program and they work through those first 3 weeks, they're likely going to see significant changes. But it's kind of like a surgery, right? You're going to hurt worse after the surgery with the hope that it's going to be better afterwards. But that's a big ask. And people don't know if we're talented snake oil salesmen or if we're 100% legit.
That's so true.
And so what I hope people hear is we're 100% legit. But I also want people to know that just like any therapy, it doesn't work for everybody. The vast majority we can help, but there are people who are going to need something different. And that's okay.
And that is okay. Exactly. Exactly. Well, I feel like this has been such a helpful overview. I know I'm going to go back and listen to it again because there's so many just different tidbits and statistics that I want to make sure that I can remember. Do you want to say anything else about anything we've talked about today or even about Nystrom's behavioral sleep medicine program?
Well, I want to thank you for the opportunity to get word out.
Of course.
And that's one of the things that we're struggling with most is we can address providers, but getting to patients and having them know this is available is a challenging thing.
Sure.
You and Brett have an amazing podcast.
Thank you.
I mean, it covers so many issues. And what I hope is that we can somehow grow your audience because even with other therapies like prolonged exposure, EMDR, DBT, it's not until there's a general public awareness that these things exist that patients start requesting it.
That's so
and so
true.
We have excellent therapies for so many different concerns and problems. But when people go to their doctor, they don't get, well, you should do CBTI. They get, okay, here's a medication.
So true.
Right.
So true.
And so the big thing that I would want to get out is if you are one of the Everyday Therapy listeners, spread the word.
Spread the word.
Put it on your LinkedIn posts. Tell people about it. Take a snapshot of your little QR code and give it to other people because someone out there is going to be reached and affected and it could change their life.
Exactly. I know that I'm definitely going to be sending these couple episodes to various women that I know who have all manner of different sleep concerns, just that I happen to know about in my personal life. And then additionally, my clients and colleagues, I want to know about this because, again, like you said, there are so many different ways that sleep disorder or sleep symptoms can manifest themselves, and it could be any one of many different factors. So it's worth investigating.
And there's talk that sleep is an additional vital sign because it affects so many physical health. It affects so much mental health. It affects sense of well-being, quality of life. So we need to address sleep. And again, Nystrom's has been so forward thinking in adding these services, because we do want a holistic approach to the person. You're not just a diagnosis. You have a context to that diagnosis. And that needs to be taken into account.
Exactly. I'm so glad you said that, because it's not just about diagnoses. It's like we are complicated creatures. We have a lot of different things going on at any given point, and there's help out there. So if you're listening to this and you're like, I need to get on top of this, I want to reach out, I think first visit nystromcounseling.com. There are many different ways to explore the services we have here. You can get in touch and schedule with a therapist. You can get more information about our sleep program. So that would, I think, be a good starting point. And obviously, Right.
They can also call the Nystrom line and be connected with any of our schedulers or call centers. They know we exist. If you call and say, I need help with sleep or I need help with my trauma, they will get you connected with the right people.
Exactly. We have, I think we're in 5 different states now. So again, we have tons of clinics, and with the fact that we can do telehealth, video appointments, it's like, even if you live in a rural area and you're like, well, gosh, I don't have a Nystrom's near me. Again, we have I have therapists at our Bloomington clinic that see people all over the state.
Right.
And so it's no longer as difficult to access these services. So I do want to say this number really quick. So 844-697-8766. 844-697-8766. That's our phone number. And again, you can visit nystromcounseling.com. We have lots on social media. And
it's a phone number that could change your life.
It's a phone number that could change your life. Exactly. If you've been struggling with something for a really long time and you're like, gosh, I just don't know if there's help out there, give us a call. We have many, many different people that want to help.
Yeah. And if we don't offer it, we can connect you with someone who does.
Exactly. Well, again, thank you so much, Rick. This has been such a great experience, and I know we'll have you on again.
I'll look forward to that.
Yes. Take good care. We'll talk to you soon.
All right.
Thank you as always for listening, and please be sure to leave us a review. While this podcast can't be a replacement for therapy, we hope you enjoyed our discussion today and join us again next time. Nystrom & Associates is always available to those who are struggling. If you find yourself in need of support and help, please check us out at nystromcounseling.com.